the one thing that data is often viewed as some sort of grade, if you will. I joke in some of the talks that the minute you're born, you're given a score. It's called an APGAR score in your birth, and it just seems to go downhill after that. And an A1C is a number. Blood glucoses are a number. This is an interesting perspective. I don't think I discussed it very thoroughly in the book, but when I was diagnosed, we did urine testing. And urine testing was consisting of colors. And so there were different colors in a test tube that reflected the amount of glucose or sugar that was in the urine. And so I didn't feel judged by the fact that orange was a color, and that meant there was extra sugar in your urine. Blue, maybe the fact that blue is my favorite color now is why that was created, because it meant there was no glucose or sugar in the urine at that time. So I was not handicapped, I guess, or burdened by an expectation of either an A1C, because those weren't developed until I was an adult, or glucose values, which also were not developed until I was an adult as well. So I was spared that growing up with that sort of judgment hanging over my head. And so I try to de-emphasize the numbers, for one thing. I point out to my patients that blood sugars are constantly moving. Like I said before, the only person with a straight line blood sugar is a dead person. We expect that. And guilt and shame are the first things we bring into diabetes, and the first things I try to kick out of the room when diagnosis occurs. Sometimes those things are leveraged against patients. I will be very honest with you about that. I know doctors that do that sometimes they leverage that guilt to get parents to motivate them or motivate families. I think that's a hollow victory, because eventually they learn that that's not going to work. And I let those behaviors go many years ago in my own practice. I don't yell at people. I don't look down on them in any way, shape, or I can't. It doesn't empower people. Empowerment is the key. It works for me, and it works for just about everybody else I see. Sometimes it takes a little bit longer to get them there, especially if they've grown up in a family or been seen by a provider that's used that as their sole tool of motivation. And then it sometimes takes a while to rehabilitate them into a different mindset. But I don't like to give up on anybody. I like to give them their time and realize that some people just take more time than others. If I'm a researcher, then the A1C becomes an issue because I'm trying to prove a point in a research paper. If I'm a patient, I'm going to hear from my provider. They're going to either smile because of my A1C, or have a neutral look, or have a frown perhaps on their face because of the A1C. And so I'm going to not register that necessarily intellectually, but sometimes emotionally. And if I'm a child, most of my registration is going to be emotional in nature. And if I'm trying to empower a child, and quite honestly adults as well, I think that we all are emotional beings, the more positive I can be, and to find the more the upside of things than just focus or dwell on the negative end of things. And an A1C is just a passing period of time. It reflects something that's happened over the last 3 months. I've known many children and adults who had high or elevated A1C values, which went on to then drop those into much more desirable ranges and maintain them there. Yet if I had dwelled on that one negative and found all the flaws in their care, they probably would have had a harder time coming out of that problem. And that's what frustrates me sometimes when I'm talking to doctors and trying to teach them how to look at blood sugars. When you're looking at blood sugar data, for example, that a patient brings into you in your practice, the first thing that I try to do is point out the amount of effort and time it went to collect those data. And sometimes these are still written by hand, of course, in books, and there's blood smeared on, and that's a quality book right there. It's got to be in different pens and different times of day, and there's blood on the book, and it's dirty, it's dog-eared on the edges. That's a quality log book. That's a working log book, as opposed to something that everything's written all neat and nicely and all at the same time, which he just was taking it maybe out of the meter. But either way, I acknowledge the work and the effort that goes into that. I teach doctors, and I'm a residency director for a training program. I teach them to acknowledge the effort and not then immediately, what happened here, or why isn't there a value here? You start finding all the negatives, dwell on the positives, and you get people bringing those data back to you. That works more or better than anything else I can do than to empower and acknowledge the work, because those individuals, those families are putting that effort into the management, and that needs to be recognized and rewarded. And if it's done so in the role of the physician, provider, the consultant, what have you, then I can't imagine more of a boost to that family emotionally than, hey, the consultant said something very nice about how much work I've been doing. That makes them work harder the next time. Don't sit there and set the bar so high and say your A1C is now 6.8, and you focus on that, because next time if it's 6.9, the patient's going to feel that they disappointed you somehow. I do not dwell on the numbers for that very reason. I'm saying, hey, you're in range. That's great. You're in range, okay? And you're working very hard to accomplish this. I respect that. I acknowledge that. That's how I practice. That's how I teach people to try to practice if they'll listen to me. I think that attitudes and beliefs about what this represents can be misinterpreted. For example, some people may think that you have to be on an insulin pump to sugar serve. In fact, as I pointed out previously, I was on multi-dose insulin therapy when I developed most of this, what's in the book, and I had to go back on a pump to prove that it worked with the pump as well. So I think I dispelled that myth fairly quickly. Another one that's fairly prevalent is that you have to be using a continuous glucose monitoring device to sugar serve. Our paper from 2012 showed that if you just maintain a more close engagement with your blood sugar data through our frequent pattern management concept, you can maintain better control than simply seeing your provider every 3 or 4 months and having a new set of orders issued to you that you will faithfully follow, hopefully, but not vary from in any significant way. Sugar surfing is essentially management in the moment, and I think it does require a certain basic understanding about how insulin works, how food works, strategic checking of blood sugars, whether it's with a CGM or with blood glucose monitoring. And I think that sugar surfing can be done with any modality. Quite honestly, I think that pumps do make it a little bit easier, I suppose. I suppose, of course, that CGMs make it a little bit more convenient, and a lot of our care is driven by convenience. And I speak from experience. When my first insulin preparations were given to me in a glass syringe, which had to be boiled for 20 minutes in a strainer and then cooled down for 10 minutes before I could even take an injection with a needle that was reused until it became dull. So I appreciate the term convenience very much, having benefited from that as a patient. However, there's certain things about sugar serving that can be done that are less convenient, I suppose, and still drive the train on this and make it work. When I want to give an extended or combination insulin delivery through the insulin pump, I just have to program that in, and the pump will give me some insulin up front and extend the delivery of the second portion. When I'm trying to do something comparable with MDI, I will give my initial upfront dose, which is not the full amount for what I'm eating, but then I call them I chains, and like a link of chains that overlap, I know the duration of my insulin action, and as soon as my insulin effect starts to wear off for the first injection, I start to see it inflect down, I will take another injection. And I will actually take 2 or 3 injections spaced about 2 to 3 hours apart to cover a very slowly digesting meal. And in where I live, those can be high protein, high fat containing plus carbohydrate meals. Pizza is a good example. I'll have pizza boluses, which will be 2 or 3 boluses over 6 hours to cover the pizza. Whereas with an insulin pump, I might give that bolus over 6 to 8 hours extended. But I can still accomplish the same goal with MDI. Now, again, convenience rears its ugly head here. For me, I have no qualms in taking an additional dose of insulin, whereas maybe some of our younger patients out there might, not want to take 2 or 3 injections to have a couple slices of pizza. So it comes down to, that's a choice, but I can make it work either way. Yeah, I think one of the biggest cautions that we convey to people is stacking the insulin. In fact, the insulin pumps are based on a principle of the duration of insulin action, which is meant to buffer the amount of insulin to be given to prevent insulin stacking. I will tell you from practical experience, since frequent monitoring with a CGM device allows you to see in real time what your blood sugars are doing, that every now and then stacking is something that can be done. Now, I would say this, it does help to have a CGM device if you're going to stack insulin, unless you're willing to check your blood sugar every 30 minutes. I don't think most people, practically speaking, are inclined to do that. So I do think that that's one angle of CGM use that comes in handy when you're sugar surfing and you are entering into a stacking situation. And what I mean by stacking would be, say I take an insulin dose and I consume a certain meal and I start shooting up, my blood sugar starts vectoring up very quickly, and I know that I just did not take enough insulin for what I ate. I just, underdosed. I will take an additional dose. Now, whether you want to call that stacking or just say I'm just taking the initial bolus a little bit later, that's another matter. But sometimes I will find, due to the effects of stress, illness, and so on, that the insulin effect itself it's another variable. And so if I can see the outcome, that is the blood sugar, I will be inclined sometimes to stack insulin dosages. Now I talk about this in the presentations and so on, and I talk about it very thoroughly in the book. But stacking insulin is a very powerful tool, and it's not to be used lightly. And I would not enter into that as my first foray into sugar surfing, is to start practicing stacking insulin. But just like there are accomplished athletes that do death-defying stunts, you could say stacking might be close to that, but you have to know what you're doing, and you have to watch your glucose trend line well, or check frequently, because and if you overdo it, and this will happen whether you stack or not, you're going to be perhaps risking a hypoglycemic or a low blood sugar down the other side of all this. The beauty of the device is that if you're checking frequently or have a CGM, you see that event happening. So as you're falling, you can make a decision about when to step in and consume carbohydrates to break the fall. And I do that a lot. And it's no different than if I was teaching people how to hit a golf ball. If I were your coach and teaching you how to hit the driver, and then telling you that if I teach you just right, that you'll always hit a hole in one, you would laugh at me. You'd walk away. Now, the game of golf is based on the concept of par. You have a certain number of shots to get to the hole. And so certain foods have a different par, if you will, than others. And just getting the insulin dose just right, counting the carbs just right, dosing just right, is no guarantee that 2 to 3 hours later you'll have ideal in-range control. And so having frequent monitoring, whether it's a CGM or blood sugar checks, allows you to see on the downside as it's coming down if you've overshot and whether you need to trim it out and take some additional carbs. That's what I love about the technology, at least for the CGM, is if I overshoot with insulin or underdose with carbs, if you will, I can then recover on the backside and not overshoot. And then the decision making comes down to, as I'm coming down and I'm falling, when do I actually, so to speak, pull the trigger and consume some fast-acting carbs to break my fall. And that also is part of the learning experience with sugar surfing, which I go into detail talking about, so you can trim out your dropping blood sugars. And if you miss it the first 2 or 3 times, that's fine. That's called learning. That's how you practice. And when I played tennis as a child, I was given a basket of tennis balls and told to hit a serve. It took me months to be able to hit a topspin serve, but eventually I hit a topspin serve. I have a lot of doubles trophies to my credit for that ability, but it took a lot of practice. And so I think the same principles I learned in sports, which is practice and dedication, and being able to deal with losses, learning from your losses, learning from your mistakes, is the secret that's all behind sugar surfing. The role of basal insulin in sugar surfing, in diabetes in general, is extremely important. In fact, it's one of the centerpieces of the book, is making sure that basal insulin is set properly, whether it's by a pump or with an insulin injection. And that's for a very simple reason, that your basal insulin is just meant to simply keep things steady. In other words, the amount of glucose entering the bloodstream is comparable to the amount of glucose exiting the bloodstream. So, and that's what basal insulin aims to manipulate. Now, even that's a tricky business right now, because sometimes we increase our disposal of glucose by exercise on an otherwise appropriate basal rate. So it contributes to the drift and the flux in our blood sugars. And so understanding that and embracing that allows us to take preemptive measures if we need to do that, or at least reactive measures to treat it if it does happen without our awareness. But basal is very important. We don't want to run basal heavy. In the United States, there's a general tendency for us to put people on too much basal insulin. most likely, at least in kids, because there's a lot of snacking going on, which kids are not inclined to necessarily take insulin for, and so you're really covering indiscriminate snacking by doing that. However, there was a paper that was reported in the Japanese literature a few years ago that looked at adolescents and children that were well managed and did not do a lot of excess snacking, and their insulin needs for basal were about 30 to 35% of their total daily insulin requirements, whereas conventional pump wisdom, we put people on about 50% of their total daily insulin, and then take the other half and divide it up in boluses and corrections. So I think that a key element of sugar syruping is making sure your basal insulin is set properly, that you're not running basal heavy. The first thing that I do upon awakening in the morning, the very first thing before I roll out of bed, is look at my basal control, looking back overnight the last 6 hours. If I'm drifting down from a high to a low blood sugar, or drifting from a low to a high blood sugar all night, every night, that tells me my basal is not set properly. Because if my basal is set incorrectly, then that's going to influence everything else I do in sugar syruping. So getting a good basal level of control. Plus, if I wake up in the morning and say I'm, at 10 or 11 by your methodology, and that's where I've been all night, and my basal is set properly, if I haven't done anything to influence that, I should have been 10 or 11 all night, right?
Yeah.
So I try to get down to 5 or 6 and keep it there all night and keep it steady. And I look back every day. I've been doing that for years now. Quite often we will give basal insulin in the evening in the adult world to leverage the blood sugar down in the morning to prevent morning hyperglycemia. And sometimes that happens in some of us with diabetes. We have to deal with the dawn phenomenon, which is something that occurs in patients. But in a perfect world, the basal rate should just keep you level. Much like when you take your hands off the handlebar on the bicycle and just drive straight with your balance. That's what you want your basal rate to do. Or you want your car to drive straight and the alignment isn't off. That's what you're really looking for. It doesn't matter where you are, because if, like I said, if you're at an 11 or a 12 blood sugar, it'll just keep you there if it's a properly set basal rate. So then you use the maneuvering tools to move up and down are going to be your food and your insulin effects. And so that's how I look at it. So my basal is usually about a third to 40% of what my total daily requirement is. I don't require nearly as much basal as I used to think I did. I take a total of 17 units of Lantus a day, and I have teenagers who are taking 2 or 3 times that much, and they're adults that are now on U300 insulins, which are 3 times that more powerful, and taking 56 units of that. So I'm not terribly insulin resistant either, and most children are not. There are some teenagers that may get into that, but for the most part, basal insulin is extremely important, and basal checking is a hallmark of sugar syruping. You have to know what your basal are doing. I had a young man that had very severe learning disability and had diabetes, and he was dyslexic, and he started school. His blood sugar started going up to the 300s, whereas every morning they were in control. On weekends and holidays, everything was fine. As it turned out, when I did a little bit more probing, he's in 5th grade. There was more reading involved for the 5th grade students, and he was struggling to read, and it was causing embarrassment to him. His blood sugar shot up. He was doing nothing different than on the other days except that. So once we got him some help for the reading disability, guess what? His blood sugars improved. And it wasn't because of anything he did directly with his diabetes. So you have to take care of the whole person, the whole environment, and stress does play a huge role. So the question is maybe going a bit lighter on the carbohydrate intake each day. What benefits or what considerations would there be for sugar syruping in that situation? I think I've seen a number of people who seem to have an easier go at it who are doing less carbs, and I will certainly agree with you on that. I think the high carbohydrate intake that a lot of children like to engage in, especially in the morning time, can be a special challenge. It's not an insurmountable challenge, and I did post on that. In fact, this is in the book, the breakfast cereal challenge, for example. And I measured out the carbohydrates on 3 separate days, made sure my pre-breakfast blood sugar was in the same range, and I learned from the first experiment, applied it the next day to make that better, and the third day got it into control. But I learned from immediate observation and folding that back into the next attempt. Okay, and I think that's the secret of sugar syruping, is immediate, frequent, as I said before, pattern management. And in the case of what I was doing with the breakfast cereals, were I started with just a standard bolus for a sugary cereal that children like to eat in the United States, and then I had a very big rise that occurred afterwards, which I had to correct, and I did get it back in range. I took those corrections and then added them to the initial dose the next day. Did better, but still had a late rise. And then, because of the late rise, which I had to correct, I converted that using an insulin pump to an extended bolus. And so now I did a combination bolus for a sugar cereal. That worked for me. That may be different for your daughter or for somebody else. But then the third day, everything was in range. But it took 3 different attempts before I got it straight. Okay. Now, had I done this in the old-fashioned way, I would have had to see my doctor, shown them data, and that would have been 3 months later. Maybe they would have made a suggestion. Maybe after 3 more months, they would have said use the combination bolus. So I did this in 3 days as opposed to 3 to 6 months. And so that was the advantage of doing that. The low-carb angle, I think there'll be foods that I'll eat that have no carbohydrates in them, and I don't have to take any insulin for them. Classic for me, it doesn't seem to be classic for everybody, is say scrambled eggs and bacon. Scrambled eggs and bacon. That does nothing to my blood sugars. Yet I know people around the world that does affect some people. Again, that speaks to the unique nature and why sugar serving works for people. Some people tell me they do go up with that and they don't have anything else but coffee and bacon and eggs. But this works for me, and so I'm saying that's what sugar serving allows you to discover. What do you need to manage your diabetes? There is no universal formula out there, and I think that's also, again, I pointed out before, there's no formulas in the book. There's no answer, there's no theory of everything in the book for everybody to follow. It's that you need to discover your own unique responses to food, exercise, stress, and everything else in between, and then be willing to stay on top of them throughout the day, much like as you like to do, surf. There is no wave that's going to be exactly the same from they're all unique. Even on the same day, they're different, and you just get you have to. That's what makes them challenging. And that's what drives me to do this. I know that some people would like the comfort of having some universal answer, like in the back of the book, for everything that happens. And on some level that would be nice for a day or so, but after that it gets kind of boring. I like a challenge every now and then, and I don't think diabetes is that insurmountable a challenge anymore that I used to think it was back in my youth. I had at one of my workshops, one of the attendees was a father who's a pilot, and he was helping me carry some boxes in. And he said, "I totally understand the concept of sugar surfing because I'm a pilot." And I told him, I said, at one point I thought about calling it sugar gliding or something, but sugar surfing worked well. But he said, I have to move the airplane through all sorts of air pockets and things you don't see and deal with the unexpected and so on. And so he got the metaphor, and it worked for him on his own level. But there are a lot of things in life that you can relate what sugar serving is all about. It's management in the moment, learning in the moment, and not waiting on months to get the answers to your questions, and answering many of your questions for yourself, actually. That's the power of sugar serving. Having created several online sites so far for myself, I'm empowered by those simply by the stories that parents share, like yourselves and many of my patients. And I have to be careful about who I identify as a physician online. It's a treacherous waters I have to tread sometimes because I can't speak directly about patient care or that somebody's my patient. I guess they can bring it up, but I try to avoid doing that for privacy reasons in our country. Eventually, what I want to do is use whatever proceeds we get from the book to do more workshops. For example, I'm going to Chicago in next month to do a workshop, and I can get further outside my area of the United States to do these. And so if there are local areas that would like to hear more in person, we would have the book now. They can certainly get all they can out of the book, and eventually we'll have an ebook out there as well, and maybe an app as well for this. And this is a message. This is, to me, is a paradigm shift in some ways, and I want to push it as much and as far as it will go. And I'm trying to find a way that's not supported by any corporations, or I don't work for any companies. I'm not a paid spokesperson for anybody, and I have to make sure I tell people that at my talks. I'm not a shill for anybody. I just want this information out, and anybody that knows my story, which is in there, explains why. It's your story. It's your story. It's knowing people growing up with diabetes. It's wanting to live a full life, wanting to help other people. It's why everybody is here in this room. talk today is for that sole purpose. So I'm not any different, any better or worse than anybody else here. So, and that's what Sugar Survey is all about. And I hope it does go. We shipped the books right before I came over here, and my daughter's still shipping books internationally right now, and I'm hoping those will be received in the next week or two. And then now we have a lot of ongoing orders coming in. But I think it's a message whose time has come. It's an empowering message, as you say. I think that the medical profession will be my last challenge, is to get them to appreciate this. Certainly going straight to the patients is my preference at the beginning. But I've spoken to professional groups, I've spoken to nursing groups in the United States for the American Association of Diabetes Educators, and they're very receptive to this. I think honestly, my biggest challenge will be endocrinologists, because speaking as an endocrinologist now, put that hat on, we all kind of think we know everything, and I'm just being totally transparent, and I understand that mindset, and so that may be the most challenging group to reach into, because I'm trying to explain something to people who feel like they already know what they need to know, and that's a bubble or a shell that's hard to crack through for some people. But I'm not an evangelist, like I said. I'm here just to help people who want to be helped. Some people take longer to come around than others. I respect that. I don't get mad at anybody. I just say sometimes they're just not ready yet. It's not their time.